that has like the, if you have questions, email.
All right. Do you want it now?
Yeah, she just wants to
I'm
make
just
an
going to make a quick announcement,
Oh, yeah, okay.
and then you could switch it to
Okay,
this.
just give me a minute.
Okay.
Never mind. Let me just do this real quick.
This one. Hello, everyone. Before we start the next session, oops,
It's a looping slide.
it's on a loop.
Yeah, so
I just wanted to let you know that if there are
just give me a minute.
any questions or comments or priority areas that you'd like to email in if you don't have a chance during the session, please feel free to send it to this email address. So I just wanted to let you know. So Cece and her team have allowed us to take your extra comments, so please feel free. Thank you.
Welcome back to the session. Welcome back to the session. Today we will have four very distinguished panelists who will address specific issues that will be given to them. The structure of this session will be like the last one, that each of our panelists will give a brief answer to a question, and then we'll have a panel discussion where they'll be following up on some other specific questions for another half an hour, after which we will have a Q&A from the audience, and then a wrap-up, which will be 10 minutes. As you know, the objective of this session is really to look at supporting the individual needs of people with declining capacity. Because in the previous session, we talked about the healthy aging population. So this is when we start individuals having needs of when the capacity decline. The objectives are to consider contemporary challenges for quality healthcare service delivery, including patient preferences, integration, workforce issues, looking at innovative healthcare models, which may include population-based models from individual community, and then looking at how we have quality healthcare approaches that recognize the individual's autonomy and to be able to measure patient-related outcomes and improve individual capacities, and looking at technologies and enhancing the quality of healthcare. I forgot to introduce first I have to introduce myself. I'm Leocadio from the Chinese University of Hong Kong. I'm head of the School of Public Health and Primary Care. And we have four very distinguished panelists. The first panelist is Dr. Leocadio Mañas, who is a professor of geriatrics at the Universitario de Madrid, and also scientific director of the Spanish Center for Biomedical Research on Frailty and Healthy Aging. His main lines of research are on frailty, diabetes, and models. He's also head of the Joint Action Advantage funded by the Sante, which aims at building a European roadmap to face a coordinated and homogeneous way at the clinical organization public health challenges of frailty. Our second discussant is Dr. Maggie Cabell, who is a general practitioner. She used to be a full-time partner. Her particular interest is in gerontology and end-of-life and palliative care. She continues to do work in this area, and she's clinical lead for the integrated care for older people in Worcester. It looks at all stages of aging life course, from those who are aging well to those who are living with significant dependence. And the program will incorporate NHS England's long-term care plan for aging well, to support improved coordination between primary and community care to support older people to receive the appropriate care in the appropriate place and in the appropriate manner. Our fourth panelist is Dr. Leocadio. I'm afraid I have a problem with Piniswachitara. Okay. He's a medical doctor of medicine, but his career, he's now moved to policy. He used to be director of health promoting hospitals, then moved on to director of regional health center and also the director of the Bureau of Elderly Health. Currently, he's the director of the Bureau of Health Promotion in the Department of Health in the Ministry of Public Health in Thailand. He founded the Health Promoting Center for Elderly People and developed the changing of healthcare behavior curriculum and developed the health handbook for older people in Thailand as their personal health surveillance and basic self-care guides. Our fourth, but certainly not least, panelist is Professor David Lindemann. He's Director of Health at the Center for Information Technology Research in the Interests of Society in UC Berkeley, and Director of the Center for Technology and Aging. He's got a long career in health service research and gerontology, conducting research related to healthcare technology, assistive technologies, chronic disease management, healthy aging, disabilities, dementia, and many different areas in healthcare. His current focus is working with researchers, entrepreneurs, and investors on the incubation, startup evaluation, and scaling up of technology-enabled healthcare solutions. And these technology-enabled solutions cover a continuum of healthcare, ranging from wellness to complex chronic diseases and precision health. So we have a very, very distinguished and interesting panel. And we'll start the session first by from Professor Leocadio Mañas to give his comments on this question. There's a strong focus on vertical approaches to health, often leading to negative health outcomes and experiences such as polypharmacy and falls. To what extent can community-based models and innovative interventions focusing on function and community co-production optimize capacity, build better health outcomes, and delay care dependency for present and future generations?
Thank you. First of all, thanks to the organizer for the kind invitation, and mainly to Aislinn, that unfortunately cannot be with us, but hopefully she will be able to do that in next occasions. I think that to answer the question, we need to look at the characteristic of all the people when they become sick, because they show quite clear differences with adults and young person. And among many others, I think that there are four main characteristics that make put the difference. The first one is the aging process per se, that is accompanied by losses both in the intrinsic capacity and in the functional reserve. Second, the presence of chronic diseases. Chronic diseases, as the name say, are chronic, so they are not cured. And this means that people with chronic diseases maintain their status of sick people until they die. Second, as these diseases are in contrast with the things happening in younger people, young people die from the diseases, but older people live with them and die with them, because it's not quite clear that they die from the diseases they are suffering. As they do not cure of these chronic diseases, there is an accumulation of chronic diseases, raising the issue of comorbidity and multimorbidity. It's interesting to think that each disease produces different risks to different outcomes. So when they are presented in clusters, the management of this cluster of diseases are different depending upon the components of these diseases. And the fourth and probably the most important characteristics is the impact on functioning. The phenotypic expression of the interaction between diseases, aging process, and subclinical impairments when you are old are functional impairment, and not head pain or back pain or things like that. You experience a deep functional decline. And this functional impairment is the main factor associated to poor outcomes, both for the individuals but also for the health systems. From an individual perspective, functional impairment and disability, but not diseases, are the best predictor of hospitalization, death, incident disability, but also from the health services perspective, this functional decline are the best predictors of costs. For some data, they explain around 70–75% of the cost structure, and they are able to account for around 70–80% of all the costs. Two examples. Frailty increases in 2 to 4 times the cost of health in people older than 65 in France, in Germany, or in Spain. The second example, in the United States, older frail people who represent less than 10% of patients attended by Medicare account for near 50% of the patients in the top 10% of health-related costs. And more interesting, 50% of these costs can be avoidable. So with all this data in mind, it looks clear that the classical approach, based on a vertical one-by-one management of diseases, not considering functional impairment or social consequences, is no longer sustainable. What should be the main characteristics of a modern model of care able to give the right response to the current needs of the current patients, avoiding disability? First, the model should promote what some people have called a clinical transition. That means put the focus not on diseases, both isolated or as comorbidities, but in functioning. The system should prioritize functional deterioration, its prevention, detection, and early intervention. And regarding prevention, we as clinicians are very convinced of this approach for some diseases. For instance, cancer. When we think in cancer, we think in early diagnosis or indeed in prevention, not in treating them when there are metastases. In the case of functional impairment, disability should be or could be equal to metastasis, and frailty could be like carcinoma in situ or lesions not well developed. So the idea of early prevention in functional deterioration is a very classical idea among the usual conceptual framework in medicine. The second characteristics of the model is that it should provide an integrated care. Function impairment need to be managed in addition with diseases, several chronic diseases, but also jointly to the social problems usually linked to the presence of functional impairment. These needs can be present with different severity degrees, from mild needs to very severe needs. And they change along the time. So there is not an unidirectional from disease to mild impairment and heavy impairment, but in contrast, the system or the problems can be not encircled, but changing situations with changing needs along these different situations that can be presented along the time. Third, being a quite dynamic status, this functional decline, changing from times when functional impairment is mild and without a big impact on autonomy, It always sounds in the most inconvenient time, you know. It's my first ring in 36 hours since I arrived here. So sorry. So as I was telling you, these changes are not unidirectional, so a preventive approach or an early integrated intervention are the clue to avoid functional deterioration. Accordingly, a continued care is mandatory to detect those situations of risk and to act as soon as possible. Functional deterioration does not need much time for fixing and become irreversible, and because of that, the window of opportunity to intervene is quite narrow, making the continued care a necessity. And finally, as the need of integrated and continued care is a characteristic of an appropriate model of care, the different agents intervening on the provision of care must be absolutely coordinated. Current systems used to provide a reactive, non-coordinated care who are delivering separate levels of care without any connection among them. Thus, they work as silos. We have the silo of social care, we have the silo of primary care, we have the silo of hospital care. This organization of the health systems, that after Alma Ata was considered the gold standard, now has become a true barrier for the provision of the best care for the patients. The patient needs several of these levels of care at the same time, and those needs change. The different components should perform as a unique system that, although having different points of entrance, should have its main point, but not the unique point of contact at the community level and primary care, simply because they are the levels best positioned thanks to its proximity to the people.
Thank you very much. It's very interesting in terms of the characteristics that you talk about, and we can discuss it later. We'll move on to our second discussant, Dr. Maggie Kibble, who is a leader in geriatric medicine, and she, of course, in the ICOPE implementation in Worcester. Because of Dr. Kibble's background, and of course the excellent primary care system in UK, we'd like to ask her questions of how healthcare and public health services can deliver personalized and integrated care for older people with declining capacity presently, while also ensuring better health for the future generations of aging people.
Thank you very much. Yes, I'm Maggie Keeble. I'm a GP from Worcestershire in the UK. And what I've been leading in Worcestershire absolutely is a direct attempt to join up those silos that you so clearly described there. So Worcestershire is a county of 600,000 people in the Midlands in the UK, with about 130,000 over 65s, which is the numbers projected to rise by 30% by 2030. So the ICOPE program was developed following my participation in the World Health Organization meeting in Berlin in October 2017, when the theme was integrated care for older people, when it very clearly sunk home to me how important it is that if we're going to integrate systems, that we need to be integrate. There needs to be drive from the macro, the meso, and the micro level, so that at every layer, everybody is joined up with a common approach and a common language. In the UK, we have a big reorganisation of the NHS that is happening as we speak. One of our speakers earlier on was talking about the importance of change in the work environment in order to keep our brains fresh. Well, I think anyone working in the NHS is kept fresh by the constant change in processes. So it's not all bad. So the NHS is leading the way, I believe, with its Aging Well programme, which is attempting to look at the whole population in terms of a life course approach, and looking at, it's beginning to focus really on the later life course in terms of how we manage cohorts of people living with moderate and severe frailty. But it also incorporates the preventative agenda. So with the national level changing, we needed a driver in Worcestershire to bring health leaders and social care leaders together to actually work collaboratively, hence the birth of the ICOPE Worcestershire when we started the programme in October 2018, so that took 12 months to get up and going. We're a collaboration of the health commissioners, the acute and community services, primary care, adult social care, public health, the voluntary care sector, and older people themselves, developing links with our local university and with local sports and exercise partnerships. We are considering the whole life course. We have elements of the programme that is supporting people living with mild, moderate and severe decline. And we are using the concept of frailty. We're using the paradigm of frailty because that's the language that has crept into the NHS as Finbar was explaining earlier. We have a lot of work around frailty and recognising frailty on the basis of using the clinical frailty scale to actually subdivide the population into people who are not living with frailty, and then people living with mild, moderate and severe frailty. We are developing localities in that primary care is coming together in primary care networks, supporting a neighbourhood population of between 30 and 50,000, which is a neighbourhood that actually we can begin to deliver population health management interventions. We have the advantage in the NHS of having very robust primary care data. We can use population health management if we're pulling data off primary care systems, and we are working very hard in Worcestershire to get general practice to recognise frailty and to code frailty on GP systems. For those people living with mild frailty, we're very much taking the proactive approach. We're using, somebody was asking about life coaches. We are investing nationally in lifestyle advisors and social prescribers who are going to be embedded within those primary care networks. And then towards the end, or to the more severe end of the spectrum, with people living with severe frailty, we are accepting, or we have to encourage people to accept that severe frailty is an end-of-life state, that people living with severe frailty are approaching the end of their lives. We need to see severe frailty as an end-of-life state such that we're having the appropriate conversations about realistic expectations so that we can take people on that journey to have the conversation about future planning. If we don't incorporate future planning and expectations in all our conversations with people, how can we enable them to express their wishes and preferences in order that we enable them to have the later life that they wish and a death with dignity in a place of their care. Earlier upstream, the way that we hooked adult social care and public health into the programme was talking about prevention, and for adult social care in talking about cost savings. They're very involved with a positive ageing campaign that we've been able to initiate using public health monies. We are working with an organisation called ADL Smart Care, who have developed a concept of the life curve. Finbar was earlier talking about how in health, we don't recognise functional decline until people are so far down that actually they need our help. If we can recognise that people are beginning to develop functional decline much earlier in the life course, we can enable them and give them the tools to actually make changes themselves. The ADL Smart Curve team have actually isolated various losses or various things that people can no longer do that will actually show people when they're beginning to develop functional decline. People who are well can walk significant distances. They can walk briskly, they can go hiking, they can go on walking holidays, they can get up from the floor unaided. The first thing that is the indicator that you can know that you are beginning to develop functional decline is not being able to cut your own toenails. That's a really easy concept for people to grasp, and it pulls people in when you start to talk about that. You see people stopping and thinking, and it begins to become personal and it begins to become real. And I think we need to make this whole argument personal. So if we take that in terms of the life curve, people can then plot their course on the life curve, and then they're motivated to begin to take initiatives that this is all on an app, this is all on a mobile phone, people will be able to do this themselves, they'll be able to score where they are on the life curve, and within the app actually be able to go to interventions that will enable them to make changes. By using the data, they agree to sign up to that data being used, you begin to develop a database of information that enables people to look and see what people are using, what people are doing, and the difference that it makes. So we're working on a number of different work streams. We will be starting this work in April. We've just gone out to advert and appointed 2 people to the roles to actually lead this whole campaign. So we're working with some of the domiciliary care agencies to offer rehabilitation and enabling support rather than just going in to give care. They're actually going to be working for longer periods of time to actually try and re-enable people such that their care costs are reduced. We're going to be working with carers, informal carers, to actually make sure that their needs are addressed and they can self-help as well. We're going to one of the local workforces, our adult social care workforce. We're actually going to use the county council workforce to actually get them using the app and see what these people can begin to do themselves. And finally, a big promotional campaign to really, we talked about the agenda around positive aging, to reduce the whole attitude around aging, which is inherently negative at the moment, to begin to promote the really good, happy, positive messages about aging, and I think we need to be ambassadors ourselves for that work. So we're doing a lot in very early stages. The real successes, I believe, at the moment, we're only 18 months in, is being able to get the public health monies to do this initiative. The ICOPE 100, we've got a panel that we've managed to, it's a virtual panel of people over 50, all ages up into their 90s, who are our go-to resource for asking them, for sharing with them, for doing surveys and for getting feedback. The fact that one of our most cynical members on the board, we said actually what was one great successes at the end of 12 months, he says the very fact that we're still sitting around the table. People are really engaged in this process, and there's plenty of energy and enthusiasm to move this forward. So thank you very much.
Thank you very much, Dr. Kibble, for giving us such a comprehensive overview of the system that you're developing in Worcestershire. We move on to Dr. Leocadio from Thailand, who will talk about the experiences with universal healthcare, because Thailand has made great inroads in universal health coverage in a very short time. So the question for Dr. Leocadio is, can universal healthcare be inclusive and accessible across the life course while maintaining and improving the quality and effectiveness of services and interventions supporting the unique health and long-term care needs of aging people?
Thank you very much. According to the universal health care, universal health coverage strategies and implementation plannings may be quite different from one country to another countries, depending on the local context. For example, in Japan, France, UHC is sustainable with comprehensive access to health services. And also in Singapore, I know that Singapore have the basic health insurance and also have the premium health insurance. People need to co-pay for the additional medical services. In Thailand, Brazil, Turkey also have the universal health coverage for a long time, and the universal health coverage quite have the successful story. And also, this country also have some challenges. For example, how to improve the financial protection and the quality of the services. And these are the quite challenges in this year. And for example, in Thailand began the universal health coverage almost 20 years. And currently, this right of the universal health care cover all Thai people. In Thailand, we divide into 3 schemes of universal health security. The first one is universal health coverage that cover to 70% of the Thai people. Another one is social security schemes that cover around 20% of Thai people. And the last one is civil servant medical services scheme that cover to 5 million people, or around 8% of the people. And that I have talked about the universal health coverage in Thailand, Brazil, and Turkey. This country have a successful story about the poverty of the households that caused by the burden of the healthcare costs decreased dramatically. And also accessibility to the basic healthcare has been improved, especially in the vulnerable people, in the informal labor, and also in dependent older people and disability people. The use of the UHC by the people and expenditure in this country have increased continuously, and maybe from the non-communicable diseases and from the aging population. the sustainable of the universal health coverage system have the question whether there is a sufficient health financing have become a large challenges in this country. So in order to sustain the health security system for many countries, in the long run, there should have the recommendation about the health financing management. And in Thailand, we have the 4 objectives of SAFE, S-A-F-E, S, sustainability, A, adequacy, F, fairness, and E, efficiency. And also we have some indicators to monitor in the health financing management. For example, the sustainability, we need to have some measures to control the total health expenditure and general government health expenditure at the appropriate levels. Efficiency means efficient reimbursement and price monitoring system. And also, we need to use the collective purchasing power. Another universal health coverage system that I would like to talk about is long-term care system. Now in Thailand, we established the long-term care system for almost 4 years. And under the budget of the USC, the system provides care for the dependent older people around the country. Starting from 4 years ago, from this 10%, only 10% of the dependent older people, and now extend. In this year, we extend to 90% of the 200,000 dependent older people around the country. And this system also offers the special welfare to the dependent older people. The primary care center and district level hospital have received financial support from the sub-district health fund that come from the local government. And these budgets come from the USC. And we have the 5 criteria to achieve the standard of the long-term care system in Thailand. First, having the senior citizen clubs and having preventive long-term care activities in the senior citizen clubs. And also we have the projects of friends, health friends. It means all the people help other people that have in the situation of the disability of dependent at home. And secondly, having aging people data classified into 3 groups. I mean independent group, partial dependent, and total dependent. Thirdly, having care manager, caregivers, and informal volunteer to take care of all the people in the community. And now recently we have 12,000 care managers around the country and 80,000 caregivers that passing the training course and work in the communities. Care managers come from the social workers and registered nurses. And these people are expected to coordinate care services for the older people and to function as a source of social support under the long-term care system. And the next one, having good home health care system. And these home health care system now where we have the multidisciplinary professional teams from doctors, nurses, or mental therapists to working closely in the community. And lastly, having financial management by the local committee, and this local committee have the chief executive of the local government, the chair. We have many key success factors to sustain the USC and to maintain the quality and the effectiveness of the services. And I would like to talk in the next round, talking about how to achieve the financial system.
Okay, thank you very much, Dr. Kachai. We've heard from our 3 panelists on community-based models and population models and the financing. Our 4th panelist is Dr. David Lindemann, who we'll ask him the question of how can innovation, technology, and health informatics assess health and well-being, and facilitate quality care for aging people with some capacity loss? And what is the potential of science, technology, and informatics across the life course if the adoption of these innovations and if the adoption of these innovations involve an equitable, multi-generational design and development process? Dr. Liddy.
Well, thank you very much, and good afternoon, and I appreciate again the opportunity and compliment the organizers, and delighted to be with my colleagues here on the stage. And it wouldn't be appropriate, I think, at this point to continue the process if I weren't to say, being from the Silicon Valley area, it's time for a little disruption. So I'd like to put a few points forward in terms of this that I think align nicely with the challenge that's being put forward by the national academies, because I do think disruption is what we need at this point. I do hope that this is, in a sense, a transition to what will be discussed at the third session in Japan, looking at the impact of new technology solutions, not only to benefit the programs we've heard throughout the day, but to actually rapidly move us forward. Technology and data analytics. I'd like to give a few examples of some very rapid implementation of technology solutions, some that we've been involved with, others that I've watched, that I think can really set the stage and complement what we've heard throughout the day in terms of different population groups, different ways we focus on family caregivers or carers, the way we look at the workforce, and most importantly, the way we look at system change. Because the new tools that we have available to us are considerable, and I think that we're just beginning to see how they will work. So, 3 different examples. Let me start by personal application of technology. All of us here know quite well, and many people I watched who had Apple Watches, wearables, etc., how we use sensors, robotics, etc. But what we do have now are new applications of these technologies that can be literally game changers in terms of how we care for individuals and how we protect individuals. I'll use one example of a company that evolved out of our innovation health system, which is interdisciplinary, multi-university, private-public partnerships in doing this. The company's name is Safely You, and I commend it to you because it does address the issue, unlike other technologies that I'm very intrigued with that look at prevention, promotion, healthy aging. This is used at protecting cognitively impaired. And it was developed through a root cause analysis of the major impact of what is the key issue for persons with dementia in residential settings that impacts their well-being. It's falls. Falls are the greatest cause of morbidity and mortality. Safely Used was created using a visual camera to monitor individuals in residential settings, AI backend to eliminate other information, and could actually do real-time analysis, does real-time analysis of falls. What it has determined is that it's given new tools to the workforce to prevent falls, but also to change exactly how we work with individuals in these settings. Evidence-based not only has shown that it reduced falls by 40% and continues to do so, but emergency room visits by 70%. We worked with them to take it to the state of California, where it has become the gold standard. They have now moved to 6 different states and are rapidly becoming a national model in the United States for how we work in that area. But let me shift the gears again to both family caregivers and the workforce. Other examples that we're seeing in this area are very exciting developments where we can take remote different types of concepts and take them to family caregivers wherever they are and whenever they need it. Family caregivers need support to help not only their family members, but themselves. And taking tools like powerful tools for caregivers based on Kate Lorig's model out of Stanford to an evidence-based program, and being able to then move it rapidly, working with industry and government to the national health system, to Brazil, et cetera, showed very rapid upscale engagement of this program. And again, the application to many different sectors in many different countries. Similarly, in terms of the workforce, I would like to commend to you a new company that has rapidly moved forward. It received the AARP Innovation Award, the Gates Challenge Award, and several other programs. It's called Embodied Labs. It's used a new virtual reality training program to help the workforce understand exactly what happens to individuals in their environment as they're experiencing different diseases such as dementia or Lewy body's disease, how to better care for individuals, and when mixed with augmented reality and mixed reality will be, again, rapidly, it's already moved throughout the United States and North America, Canada. It is now being applied in Europe and is being used as a low-cost technology solution for the workforce. And finally, a third area, because behind all of this is data analytics. The new approaches that we're seeing, excuse me, with machine intelligence in this area are just incredible. And the speed with which they've changed just in the last 3 years, working with many Silicon Valley companies, it's not just the Apples, Googles, Microsofts, but it's the Tencent, Baidu, et cetera, companies across the world, including Philips, Novo Nordisk, working with companies like Sampo in Japan, who are looking at new technology solutions in this area. And particularly, what I'd like to share, we talked this morning about ways that we're going to look at social determinants of health. I would commend another company that's come out of the United States, but is just representative of this area. It's called Socially Determined. It can rapidly scale both large data sets, public data sets, and proprietary data, and create solutions for systems to better understand the key factors in their area. This is now being picked up by not only dozens, but hundreds of health systems, as well as community-based programs from which this can have a tremendous impact to understand better the needs within their communities. And similarly, on an even larger scale, the application of new technology solutions, we will begin to see wonderful applications in this area across countries. We are in the process of finalizing a relationship with a first affiliated hospital, Sun Yat-sen University, and the University of California system, where we thought we had a wonderful opportunity to do deep analytics with 15 million person de-identified data set, and we found that our colleagues had simply an 80 million person de-identified data set from which we can do comparable analyses to look for deep learning solutions. So I'd like to come back to the point that what we've heard throughout the day, there are now many different new, not only technologies, but data analytic tools that are coming forward, but they are just that, they're tools. And it's how we will see them applied, how this wonderful challenge that the National Academies is putting forward will identify those tools and make sure that they are applied at a very large scale as rapidly as possible to benefit as many, not only older adults, but their families and the workforce as we can. Thank you.
Well, thank you very much, Dr. Lindemann. We've heard 4 very interesting presentations and the innovations and disruptions that we have at hand. But so the follow-up question is to each of the panelists briefly, before we discuss it in detail. It's based on the experience and your fellow panelists' comments. In your opinion, what is the evidence-based, future-backed vision of health systems we need to support health and capabilities across the life course? And some of the examples you've given, what will it take to create it? So it could be interventions or the enablers and the barriers, and it could be anything between public health and workforce development. So perhaps you'll start off by Dr. Mañas.
Thank you, Mr. Chairman. I think that now we have, thanks God, several examples on how the health systems must be rethinked. There are some change, for instance, in UK, in England, but also in Scotland. We have also some examples in France, in the zone of Toulouse. We have examples also in Spain, where we have a national health service that is centered in primary care, that is well connected with hospitals and with social services. We have also some examples in Mexico. So I think that now we start to have good evidence-based solutions to put in practice these integrated, continued, and consolidated model of care for the people, focused mainly in preventing disability, because when we approach people who are disabled, probably we are late, and we must put the emphasis in preventing this kind of situations. So I think that now we are in a good position to start to change our health systems using technology, but as David has perfectly told, technology is instrumental, it's a tool, and we need to know what we want to do the technology. What can we expect from technology? Because technology is not going to solve our problems if we not have quite clear what we want the technology is able to do. And regarding to change the balance, everybody uses to say, when make the criticism to the health system, that they are hospital-based. And now we say, no, we must go to a community-based. So we are going from one edge to other edge. And what I try to say is that use all the resources available in a proper way, because community-based is very good, it's very nice, but if I have a myocardial infarction, I want to be attended in a hospital. And as soon I do not need the hospital, I want to be continued attended in primary care. So I think that this is why I have told that we should overcome the barriers of the alma ata model that makes the silos. We need to break all these barriers, and when we conceive the reform of the health system, we need to put the patient in the middle and adapt the system to the patient, not the patient to the system.
Thank you very much, Dr. Keeble.
I think I would be really taking the public health messages, taking the positive messages about aging. I think we have to out ageism. I think ageism is unconscious. I don't know how many of you recognized the ageism in a poster that was presented, in a photograph that was presented earlier on from our very eminent colleague in Singapore. And there was a leaflet there that said, "I am feeling young in my Singapore." Young, we are promoting young as good. We say to each other, and it's a compliment, you're looking very young for your age. That person is looking young for the age that they are looking as the age that they are. We need to call out unconscious ageism. If I said to one of my gay colleagues, "You're looking very straight today," and yet it's the same, and yet we don't see it. We need to have an age-proud movement. We need to celebrate all the good that comes with age. And if we can't do it, we're the experts in aging. If we're not doing it, how can we expect our populations to see that? So there has to be a positive message. We have to call out everyday ageism. I think maybe there needs to be a Me Too era for the old Me Too. And I really think it needs to be a public message. We need to have a shared language. Our public health campaigns need to be saying, are you ready to live for 100 years? The majority of people born in the next decade will live to 100. Unless we're preparing our bodies to do that, unless we're starting at my age, unless the second halfers, I see myself, I'm optimistic that I will live to 108. So at 54, I'm halfway and I'm starting on the second half, and boy, am I looking forward to it. But that's not a universal attitude, and that's the attitude we need to be able to create, because it's not doom and gloom. I'm really looking forward to a healthy, active, positive age, and a second life, a second work life, jobs for a second life. I intend to stop being a doctor at 60 because there's so much else I want to do, and I'm really looking forward to it.
Thank you very much, Keeble. I agree completely with you. I'm in my fourth career. We move on to Dr. Ekachan, your response.
Thank you. As a policymaker, I do believe that every country should have strong commitment and measures toward a healthy citizen, healthy community, healthy environment, or, for example, age-friendly cities is a good policy for every country. And for example, that should have the public policy, law, and health promotion benefit in all age groups, and driving by various committees at all levels. That should have strong policies and strategic planning that need to produce sufficient healthcare personnel, and also the capacity enhancing training should also be provided for the health personnel at all levels. And another measures, every country should have the measure to accelerate the public communication and the health literacy through the various communication channels in society to promote good health behavior to all people. And preparation for old age for the younger generations is very important, including the health, finance, and also social factors, and are the key to sustain the development of the healthy longevity. Another measure that I would like to comment is about to empower the communities and collaboration among the various stakeholders or network partners to create a healthy environment in the communities. And recently, last year in Thailand, for example, we have an MOU on the promotion of the health and disease prevention among the working age citizens. Involves 7 agencies, including the Ministry of Labor, Ministry of Industry, Ministry of Interior, and Ministry of Health, and also the Bangkok Metropolitan Administration, the Federation of Thai Industries, and the Private Hospital Association. And the Prime Minister was the chair of the MOU ceremony for the health promotion programs. And the government will promote a new career working in the working place that call health promoters. The last measure, yeah, the last measure is about how to have the surveillance system development and data management to support the modern health service system, including development of a platform to integrate various databases from public and private sectors, and integration of data on the quality of life of all age groups, especially for the older people. Yeah, thank you.
Very nice. Let me just echo what my colleagues have said and add 4 more points, but again, they reinforce what you've said. What Leocadio initiated with putting the older adult at the center, but also family caregiver, carer, the professional workers in this space, in the idea of co-design, human-centric design around new solutions, not just technology solutions, but all the solutions we've been hearing today, central to what we need going forward. Second, in terms of education, absolutely reinforce ageism, but I would now add to it the importance of understanding data science and analytics. The fact that this should be central to all of our gerontological education programs and be put forward as mandatory for individuals working in this space, no matter what field, to understand how to use data and its applications, not just clinical applications, but again, from policy, et cetera. And then from policy, how we create a mechanism to transfer knowledge and not reinvent the wheel. The idea that we have some wonderful solutions that we've all seen, evidence-based solutions, that should be replicated, scaled, and that could be applied in different settings, whether it's in a universal healthcare program, where we have lessons that could be learned, to programs that could come to other types of healthcare systems. So, but again, how we manage and share that information and don't lose it. And finally, even though I've spent most of my career in academia and NGOs and working in a number of different types of public settings, I believe public-private partnerships have a clear mechanism now for rapidly creating and disseminating new solutions. Working with industry, which has often been questionable for many of us, is amazing in terms of their interest in our space and how we can help shape and use the speed and their ability to benefit many people much faster than can be done through public mechanisms.
Thank you very much. Before I open up this session for questions and comments from the audience, I just want to ask the panel a question relating to this decision-making by older people. We talk about person-centered care, But as Dr. Keeble mentioned about some of the ageism, which is very prevalent not just in the community but also in the health system itself. We assume that older people can't make decisions, and they come from different backgrounds, and even you work with people with dementia as well. So people don't understand that when you make decisions, there are different types of decisions, and people with dementia can also make decisions. So what can we do to enable to really have older people being able to make decisions and being able to express their preferences? Because I see a lot of difficulties, and from your experiences, I'm sure all of you have. How are we going to enable that to happen?
I think we have to accept that for anything that we're doing, we cannot use a one-size-fits-all model. I think we know that we've said earlier, already today, that age, the actual number, is not important. It's actually the context in which people are living. I think when we're looking at decision making, we need to ask people what matters to them. And also, I think when we have got a cohort of people with dementia, we need to be using very careful decision making based on, we have in the UK the Mental Capacity Act, which sets out very firmly who the legal decision maker is and how decisions should be made in the best interest of that person based on their previously expressed wishes and preferences. I know in the UK that people are not using that in the way that was intended. They don't really understand what best interests are, and they think that best interest means what the nice guidance says, but actually it's about what that person wants, and we have to ask at every opportunity what's important to you, and unless we hear the individual's voice, we're not putting it in context.
I think that's probably the clue issue, is not to think in other people as passive actors in the process, but as an active actor in the process. Of course, there are some situations, like people with dementia, that the approach cannot be so clear, but people with dementia with moderate to severe dementia are less than 3-4% of other people. This means that 95% of people can take part in the decision process about themselves. And it's quite clear that their values are different to our values, and they put in the first plan functioning and quality of life. There is some very well-known papers published many years ago. They asked to people, ladies 80 years and older, if they start to take a treatment that produce a reducing in 25% of the risk for having a myocardial in 10 years. People of 80 years old. 78% say no. No, because they know that probably when they ask, and if you could reduce this same figure in 5 years, 80% say yes. And when they ask to them, and if taking these pills produce to you some mild secondary effects, they say no. And these are their values. And we should be very respectful about their values. And the only way to know their values is asking them and putting them in the process of decision making.
Right. I think certainly the Mental Capacity Act is a very good act, right? Where you look at identifying different types of decision making and what competencies are required for the different decision making. Because I can't make a decision making to invest, doesn't mean I can't make a decisions in terms of when I would like to eat and what I would like to eat. So there are lots of these things, and I think in terms of Dr. Lindemann, in terms of the applications that help people make decisions, because we all have difficulties making complex decisions, and we need aids. I think we seem to assume that we can either make decisions or not. But instead of the gradation of the different complexities and the support that's one required, and I don't know whether that's technology that can enable one to do that.
Well, there's several examples here, everything from social robotics, where we have the examples of Amazon, Siri, et cetera, that are engaging individuals. We don't yet have the capacity within those types of analytics to really engage people for them to make the best decisions, because the interface is still not where it should be. It is getting there. It will be there shortly. Similarly, there are a number of other elements that we see coming forward, and that will be how to make it easier for people to be engaged in making decisions. Everything from predictive analytics that will anticipate your needs, issues, provide you with some suggestions, options, whether it's for care management, et cetera, to the way you just have interface with technologies. Some of you may already know that the predictions are that within 3 years, 50% of all interfaces between technology for all of us will be through voice. That will change how people can make decisions and move forward. But it also goes all the way to end-of-life care. The idea that we now have e-pulse or physician orders life, I'll get that straight yet, but electronic-based programs to help individuals, whether it's individuals making end-of-life decisions or the workforce that's working with them or the family members. We have a number of opportunities that will be enhanced by these new emerging technologies.
Thank you very much. Maybe the next time around you could tell us the application of these video applications to look at the people with dementia and to see what they're trying to express and what their needs are. Because the expression, the ways that the people with dementia express are quite different. And we can maybe through AI and do analytics of what is it they wish to communicate with the carers, and that would, I think, would go a long way in enabling them to take part in decision making.
Well, I think we're seeing certain examples, for example, in mild cognitive impairment, where individuals can easily interact with and use technologies to maintain certain functions and abilities easier. It's as we get to more advanced dementia and other types of cognitive impairments, we're, for example, working with a group that envisions how do you work with not just dementia per se, but ALS patients in terms of individuals who can no longer communicate. And the idea that right now you can do visual changes using a keyboard. Well, with the new tech systems that they have currently under development, they should be able to increase the speed 30 times from what's currently done in terms of using eye movement to communicate through a keyboard. That will be a game changer, which will have broader applications as we look at, for all of us, for example, the older worker, how we will all need to have assistive technology solutions to benefit and help us, whether it's visual, hearing, or dexterity.
Okay. I'd now like to invite the audience to take part in the discussions. You can either give comments or ask specific questions.
Thank you very much. Great presentation. So for my clinical colleagues, I heard a number of times, I understand the need to classify patients. A mild functional impairment, moderate, severe, mild, moderate, severe frailty, to link with clinical services. But I hope you're not trying to imply that this is a clinical diagnosis, so that someone who's diagnosed as moderate is on a irreversible curve downhill. People get sick, older people get sick, and many of them get better. So could you please elaborate on follow-up and remeasurement, so we're not labeling people and giving people, others, more reason to feel ageism out there?
Absolutely, and I really welcome that comment, because that is absolutely fundamental to what we're doing. And I believe that this is one of the big risks, and that unless people understand why we're recognizing frailty, that's absolutely crucial to the interventions. Now, it's not about scaling services to whatever person's frailty it is. When somebody is acutely unwell, we are recommending, telling people not to see what they see in front of them, but what we're talking, there's the pre-morbid Rockwood. What was this person's functioning before they declined? That's absolutely crucial, and that's what we're teaching paramedics, that's what we're teaching front door doctors. It's not about what you see in front of you. You may have somebody on an A&E corridor in our NHS at the moment who is 85, incontinent, confused and immobile. some people would assume that that 85-year-old is permanently incontinent, confused and immobile, but that person may have been working on their farm, looking after the grandchildren. It's absolutely vital that we show the before. The reason for giving people an indication is that when we're doing proactive care, so when we're doing anticipatory care planning, that if you're looking at somebody who is living with mild frailty, the really positive message is that you can reverse that, you can delay that, you can prevent decline. That is a really positive message, that early frailty states are not inevitable, that if you intervene, if you give people those evidence-based interventions, strength and balance exercises, resistance exercising, weight-bearing exercise, improving sensory perception, diet, high-protein diet, remaining connected and lifelong learning, these things will actually improve your status. So in moderate frailty, then we're looking at comprehensive assessment so that you get a really good overview of that person, and as part of that comprehensive assessment we should be considering future planning. In severe frailty cohorts, future planning has got to be the primary goal, because actually what we find is that a lot of older people have capacity until they're sick, but then don't have capacity to make decisions. So if we're going to know what they want when they're unable to tell us, we've got to have that conversation before they become unconscious and they can't tell us. So the reason, and it's absolutely vitally important, that we're not seeing services streamed on the basis of frailty, we're seeing a nuanced approach, what we're calling a frailty sensitive approach, that you may have somebody of 85 who presents with a condition. They may have signs of a stroke. If that person is not frail, you go off down the stroke pathway, you have standard approach to care, and you actually will be doing everything you can to sustain that person's life and to make sure that if they recover, that everything is done to prevent them getting sick again. At the other end of the spectrum, having had conversations with the family members, having looked at a decision-making based on the lasting power of attorney or based on a best interest decision, the decision may be to support that person and adopt a palliative approach. You may have some families, some patients who will insist on a standard approach to care. You may have others where it's a modified approach. So for the same presenting situation, you may have 4 different outcomes, entirely dependent on context and choice. That is a frailty-sensitive approach. It's definitely not one size fits all. So I thank you so much for that question.
I think the question is, of course, whether one should equate assessment of frailty to a diagnosis of frailty. I think that's the question, because you can assess frailty, but you don't need to label a person as frail. You need to look at the components of frailty and address them. Otherwise, we run the risk of labeling people as being frail, and then they will feel frail, and because there's still a lot of capacity. So I think it's one of the issues that one needs to that we face, I guess.
But I don't understand why we mention this thing, and you used to say to somebody that he has cancer, he's not putting a label, or that he's demented, or when you diagnose it to a patient, you are putting a label. But this is not this.
Generally not reversible.
And?
Poor physical function can be bad today and better tomorrow.
Yeah, but
that's the difference.
No. Spontaneously, it's not reversed. If you do not diagnose an impairment in functional capacity and you not act on it, there is no any possibility to reverse to better functioning. So it's crucial to diagnose the functional status of the patient, because otherwise the function is impairing, not dramatically, but per day. So this is why it's so important to approach frailty and function, because the only way to act on it and avoid a poor evolution is to implement different treatment that are, we now know that there are approaches to improve functioning, but you must detect it.
Right. I think we're clear in terms of, I think there's a slight difference in views, but let's move on to the next question. Over there, sorry. Yeah.
Thank you, Nishika from Japan. I'm really interested in the dementia, how to live with dementia. In Japan, we have formed private-public partnership to create the new standard or the industrial guideline for dementia-friendly services or the product. With regard to the physical frailty, it's easy to, how can I say, measure or create industrial standard, such as a wheelchair for usable for many people. Of course, the individual needs is different. However, in order to provide the cost-effective solutions, we need some typical standard for every services or the product. But with regard to the dementia, it's very difficult to measure the typical needs from dementia people. So therefore, I agree with Dr. Kibu pointed out that one-size-fits-all approach, it cannot work. However, without create some standard or without create some business guidelines, the solution is very high cost, not effective, cost ineffective. So that's a dilemma. Do you have any recommendation or advice to create such kind of industrial standard for dementia-friendly services or the design? Thank you.
Any standards for industry? That panel?
Well, again, this is a global issue, and I do think that some of the key points would be helpful would be some parameters that we would consider, and that is the importance of guidelines as opposed to regulatory or regulations in this area. Second, in terms of mechanisms that can be determined based on larger amounts of data, as we look at some of the neurohubs and our Alzheimer's disease research centers, as they're now looking at other mechanisms, I think that we could eventually see more of those put forward. But I do think it still behooves us to have the large consensus meetings to help us move in that direction. So rather than say that there are any specific ones, and again, we have experts here in the field who I think could address this in a very nice fashion.
We have Dr. John Beard and then the back.
Yeah, John Beard, Gig Economy. David, I share your enthusiasm for technology in this area, but I have one concern, and it relates to what Maggie was saying about the pervasiveness of ageism. And we tend to think of technology as being value neutral, but the algorithms are derived by programmers, and I suspect they're not immune to ageism. And I'm wondering what mechanisms are we putting in place to make sure that when we have these social robotics and other AI-informed tools, that they're not just reinforcing the sort of ageist stereotypes which in fact we're trying to move on from.
Oh, absolutely. Thank you for the question, John. And it's fundamental, whether we have gender bias, whether we have age bias, it's fundamental in this, whether it's from the engineers and computer scientists and informaticists developing these tools, to the folks in terms of how they're designed, to societal issues. Again, I think this is central to how this has to be both taught. We're seeing this in using ethicists in terms of training individuals. We see this in terms of doing the co-design process, engaging older adults, and again, across the generations, intergenerational training. We've created a program for training with individuals. We use the 3,000 older adults in our OSHA Lifelong Learning Program to co-design and train 75 students every semester. This is going to be the wave of the future if we're going to start making changes in this regard. But I think more fundamentally, to your point, is the unknown biases, and that's what we're seeing in AI and machine learning, and hopefully true AI and machine learning, not a lot of the smoke and mirrors that we're seeing, but really some of the new analytical applications go far beyond advanced regression analyses into more Bayesian, et cetera, types of analytics will help us start identifying those issues and make things far more developed based on real data, and help us try to eliminate some of those biases that are either unconscionable or intentional.
We have a question at the back.
Yeah, thank you. I'm Peter Piot from the London School of Hygiene and Tropical Medicine, and not at all an expert in this field. but I've really been fascinated by the whole day, so thank you so much for that. I have two reflections, and one that's not specific for this panel, but it came up several times about the need to be people-centric, to find out what do, the people we're talking about, our senior citizens, what they want, what they feel, and so on. And so my first reflection is then, coming from the AIDS movement, we have a slogan, we said, nothing for us without us. And so I wonder whether, the simplest way of finding out what people want is to include them, to talk to them, and to listen. And are there plans for the Commission to include senior citizens, people who represent perhaps civil society groups, community groups of all kinds? Because I think that's going to be key for successful programs. Rightly so, several people have emphasized that a lot is context specific, so that's, I think, going to be important. Plus, I suspect that older people have more time and use social media more and more, so that's also could be a good source. So that's one comment, and I think it would be good for, for the work of the Commission to really resource and to include. And the second point is on ageism. I was really fascinated by that discussion. I think it's extremely important. But we're not going to solve that by other algorithms and so on. When you have a whole, the commercial pressure, the whole fashion industry, cosmetics, what have you, emphasizing that young is beautiful. Think of, I'm white, but at time there was the slogan, black is beautiful. It could be also, we have to change the norms, and for that, we need to work with the consumer industry, and, you need maybe an MTV for older people and what have you. And we're not going to solve that, I think, by a pure classic public health approach from government. These were my two questions, but thanks so much for all the work, the fascinating ideas that you're, giving. And but we need more disruption, and I think old is beautiful, or something like that,
Yes, yes. Dr.
Linda Fried, thank you so much for this discussion. I'm interested in how you get from point A to point Z in terms of having an integrated health system. The discussion reminds me of an old New Yorker cartoon with a physicist in front of a whiteboard with 1 million equations on it, and then they say, and then a miracle occurs. So can you talk about what it really takes in the face of all the health system recalcitrance to change, to actually accomplish integration, as many of you are driving?
I think personally it's going to be the people power. It's going to be having an integrated health and social care record that will be accessible by the patient, by the person themselves, and they will be able to update it themselves, and they will be able to share it themselves. And I think that's going to be a game changer in terms of actually how enabled people are to determine their health journey and to break down those artificial barriers that have been created by individual organisations with individual health records that are held in isolation. And even within the ICO partnership at the moment, there's a lot of, there's still concern about data sharing, there's still concern, understandably concern about data sharing, but we need to break down those barriers in order to make information flow through the system.
Yes, sir. You want
I think that the question is very pertinent, because up to now we are still moving in the field of the conceptual frameworks, but we have not probably gone to the arena, probably because it's not easy but for instance, it would be very useful that in many countries the Ministry of Health was fusionated with the Ministry of Social Issues. Or in a lower level, my general manager in my hospital is timely asked about the mortality, about the mean stay, but he's never asked about how many old patients experience a poorer functional status after discharge. And probably this kind of markers should be incorporated to the systems of quality control. And probably this is easier to do. Or how many patients with a hip fracture has been discharged to a nursing home instead through their own homes. Or how many episodes of delirium have, this is in hospital, but in primary care is the same. How many diagnoses of frailty have you done every year? Or what have done in the National Health Service? Since 2 years ago, in the contract that the GPs signed with the National Health Service, they include at least one annual evaluation of other people. This kind of measures, I think that could, not very dramatically, but few to few, promote this change in the health system.
I think you asked a very, very pertinent question, a very complex one. I think we're still at very early stages, and we talk about it. And I don't think we have a system where you're able to completely integrate. Because I think you really need to look at the person level. And when we talk about life course approach, we don't have the tools at the moment. We have a medical model, whereas we don't have a model for assessing health needs. And we talk about life course approach, and that's what's needed. Maybe in the future we might look at different models of funding, where you have a funding model for a person from the life course approach, and then the purchasing is from that person. And the systems then looks at what the person needs and the preference of that person. So we need to change that model completely before it will happen. And I think it's at the moment we're still looking at how we can do it within the current model. So it's the disruptions that are required for integration to actually occur. Yes, sir.
If I could also add, and again, thank you, Linda, a superb question, because again, it's, as our colleagues have all said, it's not only the issues around the personalization of data and how we use that to really do this, and everything from, as we've heard throughout the day, interdisciplinary approaches to, again, looking across how we merge medical and social models, which we know for years that we've needed, but how do we control data? So both the individual data to allow an older adult to be more independent, engaged, make self-determination, all the way through, as Maggie was saying, through how we connect data in terms of electronic health records, now using new processes such as natural language processing to collect more information, and then again being able to use data science to connect that data. But immediately, what we also need is interoperability. And that's not just in data and in technology, but it's in our systems. So until we start cracking the code in that area, I think we still have a long ways to go. But we, as we've talked about today, have many different methods to start and break those barriers down.
Any other comments or questions? Yes. Over the back.
Hi, my name is Ling Ling, and I'm from the Office for Healthcare Transformation, MOH Singapore. I have the privilege of joining the healthcare sector in the last 1.5 years after 16 years in social service. So there's a pilot that we're going to start, and my question is for the panel to advise us. What do you think is the data that is useful for us to collect? So it is for the segment of individuals' needs when their capacity decline. We target the segment of complex chronic. That would be diabetes, HbA1c more than 10 with at least 2 complications and psychosocial needs. And we have actually reached out to the existing players in the health and social side. So on the health side is primary care, our typical primary care providers from the public health polyclinics. Social side will be a social activity centers for seniors. And we also work with a grassroots-like relational group that does a lot of relational work. And the community nurses. In the pre-prep to launch this pilot, we actually work with them just to look at the workflow. And we have tried to codify a more efficient workflow for shared care using a mobile app, so using a technology to insert and try the intervention. So we are about to start that project in about second half of the year. I would really appreciate learning from the panel what is the data from health and economic and cost perspective just to share that we took a dimension of looking at their medical, social, functional, and activation needs to do the intervention. Yeah, so really appreciate some advice on what data should we collect.
Maybe a quick one, because otherwise we'll be too detailed.
Very quickly. First, you know that in the past century, British geriatricians show that function cannot be calculated from diseases. And this is where the comprehensive geriatric assessment include, in addition to diagnosis of diseases, diagnosis of function. So first, data you must collect are functional data. Second, when you use the term complex chronic patients, there are simple patients, simple chronic patients, because if some of them are complex, this means that others are simple. And when you are old, it's not usual to see simple. So I would like to eliminate this kind of labels. This is a true label, complex chronic. And third, you should monitor the evolution of these functional parameters along the time. I think this is our three simple messages to be taken.
Okay. Can I ask the panel, one of the questions that we didn't address was the workforce issues. I think some of the issues relating to ageism and the issues about coordinated care and integration really relates to the workforce. I think earlier on we talked about the training of health professionals, because we label people into different specialities. So in UK, you have a good system of primary care where you have undifferentiated, so-called undifferentiated patients that come along and then you refer them on. And the way that we train doctors and nurses in specialization also creates issues relating to these barriers and integration that we talk about. And the capacity to look at people from a more holistic point of view, because the doctors in each specialty are only interested. I was told that even in cardiology, some of our professors are only interested not in cardiology patients. They're only interested in not even in specific arrhythmias, but the type of arrhythmias that they are doing research on. And all the other things, they just throw them off to the rest of the staff. So this is our current system of specialization. And how are we able then to provide this more integrated care when our system of specialization and training is so bizarre, right?
I think that's beginning to be addressed. Again, I think it was Finbar that mentioned actually that there's an appreciation now at high levels in the UK that we need people to be generalists and specialists, that they need to have an understanding of how to approach people living with frailty or functional decline, however you choose to describe it. And I think we need also to come away from, I know our primary care, our district nursing colleagues, community colleagues, their job has evolved into a task-based approach. Then they're not enabled to see the person holistically. So I think we need to be changing the way that we manage cohorts, that we need to have a locality-based awareness of who is in our cohort and how we actually can support them holistically, rather than just seeing somebody with a need for addressing change or for an insulin injection. We actually need to be able to enable our staff to see, and actually that encourages people to, they actually get a much greater sense of well-being when they're working in that way. And I think for primary care, one of the things that we're looking at from geriatrics interest in GPs with an interest in geriatrics is how we can enable people at different stages in their primary care career to actually effectively specialise in older people's care and to be able to take on that holistic approach. And I know from experience of talking to many of my colleagues that we have people staying in primary care for longer because they're enabled to work in a different way. So it suits some people, it may not suit others.
Very briefly, I would just suggest that regardless of whether we're looking at geriatricians, geriatric nurse practitioners, social workers, pharmacists, therapists, anybody in our field, when it comes to technology and data, the key issue is that people need to learn how to learn, because they need to understand the processes that they're dealing with currently, because the technologies that we see today will be different, not 10 years from now, but 5 years from now, 3 years from now. Particularly if you look at how quickly smartphone, the iPhone's been here 12 years. How that has been so disruptive. If you look at wearables, that has only been fewer years than that. That has all emerged quickly. And when we start looking at how we're going to use data and how we're going to use technology, individuals currently going through the system and those of us ourselves, I believe, still have to continue to be able to learn and anticipate how the next generation of technologies and data science will be available and how we can use them best.
Okay, I think we have time just for two short questions. One here.
I hope it's not too short a question, but thank you very much for a very interesting afternoon, the panel. John Wong for organizing a great meeting. I'll start from left to right. I think I have three questions.
Please just keep to one, please.
I'll be very quick. Dr. Yeo, you were talking about decision capacity, and I think it changes from those from the 80s to the 90s and to the 100, and I'm not sure whether the legal process has kept pace with that. How does that interact with the legal issues that goes into things like testamentary aspects? Dr. Keeble, you mentioned about looking young for your age. For those of us here in Singapore, there's a very common introductory expression. It's in Hokkien, it's called chia pa. Have you eaten? Perhaps it was because it was considered a privilege or something that's fortunate in order to be able to put food on the table. Those of us who are involved in dealing with diabetic heart and hypertensive patients, we spend most of our time telling our patients not to eat so much. We're telling them to lose weight. So it's rather dissonant from the message of eating. To Dr. David Lindemann, I look forward to the day when we have voice-mediated communication. But you know that a lot of my 80-year-old, 90-year-old, and 100-year-old patients don't use the email. How do you communicate with them?
Okay. Very quickly on the Medical Capacity Act in UK is a very, very good model. It doesn't deal with age. It deals with people's mental capacity in terms of making decisions, and that has a legal basis because you use it to make decisions, whether you make decisions for end of life or for advanced wishes or for powers of attorney. Because currently many of the systems don't have good legal definitions of mental capacity. So I think that's quite a good basis. So it doesn't deal with age, it just deals with your mental capacity. You want to address the other questions?
Just very quickly, Dr. Howe, I think the key issue, as I was saying, is we now start seeing voice, as we see ubiquitous data, as we see not only smart homes, smart communities, smart buildings, we will have data collected from around us, and ideally it will be ahead of us so that our older colleagues who may have challenges in communicating the technology will be ahead of them and beneficial for all of us.
And turning around the compliment, you're looking very young. I have a 93-year-old friend who is my inspiration and my role model. She retired at the age of 90, having worked in the field of medical ethics for 50 years. She now has got so bored in retirement that she's volunteering 2 days a week in a school. Somebody said, you know, you're looking amazing for 93. She said, this is what a 93-year-old looks like.
The last question here. Yeah.
Dr. Lindemann pointed out that advances in data science will be able to integrate data from multiple areas, domains of knowledge, to produce predictive algorithms, and would move from regression analysis to Bayesian analysis, which will actually give them much better value. I entirely agree. Bayesian analysis will also, however, be dependent on the priors, which are context dependent. And therefore, given the fact that the context may vary from country to country, and even within the country between population groups, how would the prediction algorithms developed, for example, in advanced economies be relevant to prediction in low and middle income countries where you may not have access to so many data sources and where the context may be somewhat different? And what's the portability of these algorithms, and how situation dependent would be these algorithms, and would those countries have to develop their own capacity quickly in order to develop their own algorithms?
Superb question. Thank you for pushing it to the next level. because those are the limitations. And again, one of the areas that I don't think we address sufficiently in the challenge that was put forward, even though we see wonderful comments about the innovation, scaling, et cetera, I think what we need to be looking at is both affordability and equity, but also then in terms of how these analyses will be the same issue. How do we anticipate both lessons learned in applying them in other settings, and or can we develop proxies to advance this? Or are we unfortunately still going to have a very different set of abilities or applications of some of these analytic strategies? I think it's one of the fundamental challenges you've just raised. How do we push data scientists forward to understand those differences and not just take solutions from high-income countries? Absolutely.
Okay, I think we will now do a final roundup for each panelist to just respond very quickly to a question. Based on the perspectives gathered throughout the session, what ideas, thoughts, or examples do you think were surprising or insightful? What do you think would work on, disrupt, or transform your field towards a healthy longevity future? Yeah. So if we start with you, Dr. Mañas.
Very quickly, I think that the issue is in putting function in the core of the health systems, at least for older people.
Okay.
I think it's making it personal. I think we have no option but to get older, and if we see ourselves as the future old and we all embrace that attitude, we may actually, when I talk about what I do, and I talk to people about the situations, whoever I'm talking to always has a story about their own family. It is personal to all of us. We all have aging parents, or we're aging ourselves, or we have children who relate to their grandparents. It's real for all of us, and I think we need to make it visible and to be celebrating all there is about older age. Thank you.
Okay, Dr. Getafe.
In my opinion, we need to strengthen the universal health care with the responsibility, equal responsibility for the health expenditure among the public sector, private sector, communities, and family.
Okay.
And relating it back to the challenge that we started the day with, I would add, in addition to innovation, scalability, evidence-based, the importance of the really key issues around person-centric, how we engage individuals in these issues and design of programs as well as technologies. But the two key issues for me, sustainability, how we find, whether it's in universal health care or in any other system, mechanisms to maintain these programs, and everything that we do that is actionable.
Thank you very much. I think it's been a wonderful session where we heard from 4 very distinguished panelists on the different community models and the approaches to population-based to provide personalized care for people who are starting to having functional declines, the role of universal health coverage in enabling that, and the innovations done even in Thailand, where they started in a middle-income country, where they were able to put in the mechanisms for UHC and then moving on to long-term care. And then we also heard about from the technologies and the capacity. Of course, the key part that seems to be resonating is that we need to really build in functionality in our assessments, which will really then enable us to look at the individualized needs for each person. And how do we, within our system, then enable this integrated care to occur, where it's through financing, through public-private partnerships, through collaborations with civil society, and then how technology enables us to do that. And of course, technology is now a very exciting enabler in terms of disrupting, but also the limits of technology at the moment, the applications of the algorithms to other systems, which we heard about, and then the engagement, because now there are a lot of innovations which are being co-designed. I think the co-design elements is quite important, both in terms of decision-making with the patient, with the person, and the community involvement in co-production of health. And of course, it then goes on to the information technology. how we then build in all the stakeholders' needs in the design of these systems. So this is a great session, and thank our 4 panelists and the audience for taking part and for your contributions. Thank you. Thanks so much. Yeah.
She's head of our robotics program, and she is doing wonderful work in that space. And again, she would know little about that or many of these other elements, but she knows how to then apply the technology solution and in a sense wants to create international training programs. But again, for not having that space, it was superb. Thank you.
Good afternoon, everybody. So we don't have a break now, but I'm sure if you have a wearable with you, it's probably reminding you to stand up or to breathe, right? So can we just stand up for 30 seconds? I know it will be a little bit challenging now with all the sitting arrangement. Let's stand up for 30 seconds so we can at least add some healthy time into our life expectancy there. How do you feel? Better? Okay, perfect. Let's sit down and try to wrap up this session. So I am Paulin Basinga. I'm from the Bill and Melinda Gates Foundation. I'm the country director in Nigeria, but I'm not here at my capacity as the Gates Foundation employee, but I'm here as a big friend of the National Academy of Medicine. And also, as I was coming to this trip, I had a very interesting conversation with my wife because, my work, I have a lot of travels, in Nigeria, and then sometime back to Seattle in our headquarters. And then she was trying to ask me, why are you going there for this, meeting for old people? I'm like, why are you interested in this one? I was like, no, this is an extremely important meeting because, it's all of us. This, concern all of us. So I'll try to summarize. I'm a medical doctor by training, but a public health expert. I've been working in health systems in Africa, mainly, to try really to put in place systems that mainly try to continue the work of the MDGs, to really, tackle neonatal mortality, maternal mortality, etc. But as you can see, it's extremely important that we get that part right because, also the, aging issue that we are seeing now in Africa are going to benefit a lot. So I'll try to summarize, then I'll ask Sharon and John to kind of pick anything that I missed. Given that I'm not an expert in this field, this was a very good experience for me to try to see how much I've been able to learn during the day. It was an amazing day. And we had a very good opening session and then 3 quite amazing sessions. Kudos to the planning committee, our 2 co-chairs for putting in place, an amazing panel. And also there were many, many people that you didn't see here, but you saw their names, who kind of like, did a lot of thinking around, how the session will go. Please give them a big round of applause. I think we learned a lot today. So we had quite a very good opening session, and John clearly started the objective of the session, of the workshop. I really like the way they called it, a workshop. So it was supposed to work. But at the end of the day, as I reflected, I think there is a lot of work for the commissioners because we've been we tried to really be a lot of innovative, disruptive, but we didn't go into very concrete actions. I think that will be a lot of work for the commissioners as they take all these ideas to really try to see how the reports will be more concrete. And then after that, we were welcomed by Dr. Amy Kaur, who's a senior minister of state, environment, water resources, and public health. As someone coming from Africa, this was really impressive to see her CV because she's taking care of water resources, public health, environment. In Africa, you need to do a lot of work to integrate all this because you have the Minister of Environment, a part, the Minister of Health, the Minister of Water, and all of those together, there is that need for institutional change that we've been talking about. So that was something quite important. And then she said something very good. Thanks all of us for having a trust to the Singapore health system. This is why we're all here. And she stressed the need to build a strong network of healthy longevity experts to accelerate research and innovation on healthy longevity, to really try to make sure that that connection globally really try to accelerate progress. Then we moved to the first session, which was, we went to the keynote speech by Finn Bar-Martin. So I'll try to ask your indulgence here. Coming from Nigeria, there is one thing that we say all the time. We stand on existing protocol. I'm going to use, speaker's first name so that I don't get it wrong. So he did something quite, really good. He defined for us, frailty and resilience. I think we've been using these terms of frailty, throughout the day. And then he made two important points in terms of the future of healthcare systems. One, which is the primary and community care, and also say that there was a really consensus for adaptation and integration to achieve WHO definition of healthy aging. And also he talked a lot about the hospital-based care, which is quite better in recognizing how ill the population is, but not quite good in really understanding their needs at the community and home-based. And you can agree with me that even in the last session that we just hear now, there was a lot of discussion about really trying to use the frailty-sensitive approach, and also the need to both use frailty and functional capacity both together to make sure that we are not, only stuck into classifying patients, but also understanding that, there are some conditions where patient can be classified in a one way and then get better, etc. And then he ended up by, really doing something extremely well, saying that, we will need, to think about how to create a system where our, specialists, our doctors, also have some generalist knowledge into their capacity, development, so that they are able to understand social determinant of health, to really understand when they take care of patients, even if they are extremely specialized in one area, they really understand, all the other issues that the patient is, coming with. Then we went to the first session, which was a future back vision of healthcare and public health systems to achieve healthy longevity. That was a session that was really well moderated by Linda. And, she said something extremely well. She said, all the people are the only natural resources that are still expanding. So we need to take very good care of them. And there were three very, very good, speakers there. Jay, David, and Charlene. And Jay used, Finbark's analogy about the, backpack pretty well. You remember that picture that we will go with, the older person who had few years, and then looking forward with a backpack, with his gene, all the diseases that he has experienced, etc. And then he said that we need to really open that backpack of people living today and analyze, what is inside the backpack to really define the future, because the future will be based on that. And he introduced the next breakthrough in public health that they are working on with his colleagues, and then say that it's possible to get that breakthrough, during our lifetime, which is aging biology, which is really a shift to finding treatment for underlying multiple causes of disease instead of continuing to manage one disease at a time. I think we are, in this field, we're all going to look forward to see, how that work will evolve and what will come out of it. And David made some very key point here, saying that aging is not a problem, but the big challenge is really institutions that are the problem. And that institutions need to change to improve welfare. And we should not try to change people to sustain existing institutions, but we need to really, think about how changing institutions to really meet the need of the people. And also he made a point about that, aging is getting really bad press. It's kind of, similar to death in these days. We need to really change the terminology. And also, I think Professor Peter Pioggias also mentioned now during the last session, how we need to rethink how we talk about, aging. And he talked about MTV, for old people. The Gates Foundation has funded MTV, by the way, in Nigeria, and they've done an amazing job, changing the narrative of family planning. How you talk about family planning in young people, with the Stay in Life Foundation. I think if we can have an MTV for, old people, it can really change that, because it will really even change the social norm, how we look at that. And then we had an amazing experience of the Singapore example by Charlene Zhang, who really explained how the Singapore government has took the long-term perspective, which has been really instrumental to solve aging issues. And they've not looked, on quick fixes, but at least they really looked at the long perspective. They put in place community-based approaches to longer, healthy lives, and they've taken a lifelong approach, going beyond providing healthcare to promoting health. She gave very concrete example of what they're doing in schools and workplaces and communities. And she ended up by something which is quite appealing for an African like myself, because we say that it takes a village to raise a child in Africa. As you know, when you live in Africa, any person in the neighborhood can, slap you if you do a mistake, because you are a child of a community. But she said that it takes a village to age well and age successfully. And then I think this is something that we really need to learn from Singapore, from Thailand, from Africa, from everybody, because we belong to the community. The more the people who are older, they are part of the community. The example that she gave in terms of really making sure that older people are not isolated, they are connected, and then everybody in the community feel the need to be part of providing solution. I think that was really good. And then three important, discussion points in session one that I needed really to mention. The first one was around metrics. A lot of discussion about metrics, because if we don't have clear metrics, we don't have goals that we can hold government accountable to follow those goals, it will be quite challenging. And then there was a lot of discussion in terms of, the need not to spend a lot of time trying to create new index, really try to use existing index and try to really implement programs and try to make those index better as we're implementing programs. And then the second one was the whole debate around institutional change, how it's not an easy thing to do, how there are many, many interest groups that are really very comfortable to keep the current status quo going because they are benefiting from it. And then there was, quite an interesting debate as well, even in the hallway with some, in terms of, thinking about the role of the government, the private sector, and then the role of, independent, I would say non-government institutions. Like in the US, you have the National Academy of Science, for example. You have other organizations that are, putting in place some, strong, unbiased, evidence-based, and then helping to push the government going forward. As we're also reflecting in places like Africa where you don't have those independent organizations, you really need to create stronger organizations that will be, not the government, not the private sector, but really create, this debate and move it forward. And also the third point of discussion was the need to take a comprehensive approach to aging and create strong partnership between public, private sector. One potential example that was given was that if, down the road, now that human capital development has become really the narrative around global development, how can we work with the World Bank so that they change their human capital index to really include, aging component into there. So that was the first of the end of the first session. Then we went to the session two, which was maintaining the robust health of aging people. So that was really a great session that helped the workshop to move into the next level in terms of bringing up the issue more concretely and moving the barrier of the aspirational. I think you will agree with me that, the speakers really, try to raise, some of the issue, pretty well. So I would say that Ursula gave a quite great overview of the individual domains of well-being. When you look at work, school, private, and leisure, all those domains of well-being, not only considering the health care per se, but if you really look at how you coordinate, you bring those domains together, it really creates less stress for human beings to really move, forward a healthy living. And Alex used his extensive experience in, studying slums in, Nairobi and in other contexts, and also, understanding migration very well to bring the environment parts pretty well. They need to define space, they need to identify geographic areas so that we can really understand the need of those people who are invisible. And most of the people who are invisible in those places are older people. And he also spoke eloquently about, the issue of migration, internal migration, and how we can, think about that. And then it was great to have Alana Officer from WHO in the panel because she really painted the issue of injustice clearly well. Showed how, we need collectively to develop strategies that raise public awareness that, AGEs may exist and can be identified, and also it can be changed if we collectively work on that. And Kenji raised important policy and political dimensions of aging that we need to be considered as we move forward. Now, the third session, I'm not going to, spend a lot of time, given that it's still fresh in your mind, because as we brought, those issues at individual level, I think, from the morning sessions up to now, you saw that many issues really came, together to really look at, how we support individual needs of people with declining capacity, from, identifying them for providing care. We got great example from what is happening in the UK. The Thailand example was really fascinating, which is, looking at universal health coverage, how you put in place sustainable, services, that are adequate, that are well financed, and then that are efficient in terms of really taking the needs of everybody, including all the people all together. And then David did a quite, good job on bringing the Silicon Valley approach here by, providing some concrete example of, disruption of technology, how it can really help us to move forward. I'll just end by kind of, leaving you with some closing remark from the panelists, where, they say that there is a need to put the patient in the middle and adapt the system to the patient and not the contrary. Because sometimes we really try to, bring the patient to try to adapt, to our own system as, researchers and, public officials. Sometimes it's very difficult to change our own systems that we put in place because either we have a research protocol we don't want to change, either we have policies in place, or we have civil servants that are there don't want to change, and then we kind of like push all those institutional structures to the patient to adapt, but we are not willing to adapt them to fit the need of the patient. And then, we were reminded to pay attention to unconscious ageism. There was a very good discussion about that. And then every country should have strong commitment for health systems. I think as someone coming from the continent, this is extremely important because it's quite important and very difficult for all of us working, in Africa to make health as a political mandate, because most of our political leaders, they come in, they have 3 or 4 or 5 years, mandate, and the first thing they do is build, roads, something concrete that they can show, voters that they've done, instead of thinking about a long-term, intangible, health outcomes. And then the importance of understanding data science and technology and applying it for clinical and policy innovation to develop programs. And then I will just reemphasize again the need for public-private partnership, that it has a huge potential to really reach many people with innovation. So I'll end here. Probably, ask the 2 co-chair of the session, given that they've been doing, giving this a lot more thought than I have, and doing all the notes. We didn't have time to connect, so that they can at least bring this to close. Thank you very much.
Thanks, Pauline. That's incredible. I don't know how you did that with just And for those of us who are a bit jet lagged, you helped us really gel in our minds the things that have happened through today. So look, I think you captured everything that we want to capture. The one thing I would say is I think there also seems to be, to me, a positive feedback on the idea of structuring the meeting around the functioning of people, making it person-centered and using functioning as the entry point. So I'm glad that seems to have resonated with everybody. Tomorrow we will move on to people whose functioning has declined to a much more significant degree and look at how we can meet their needs and allow them to live a life of meaning and dignity. And then we'll look at how we can actually restructure the system to make concrete the aspirational changes we've been talking about today. But now it's time to relax. For people who are going to the dinner, I think Cece, or if somebody else is better about the housekeeping than I am, I think there's a bus in the lobby at 6:30, I don't know. I just got one email. I thought it was, oh, Cece, there you are. So it's here at 6:30. Yeah, 6:30 or 5? 5:30. Okay, that's much better. So we'll see you there and enjoy yourselves. And I hope we've stimulated some thinking for discussions tonight.